was trained a lot of years ago, there's a big contraposition between cardiologists and cardiac surgery about the coronary revascularization. Now, I'm working in the University of Swansea in the UK, and I collaborate with Professor Benetti, and I'm an honorary member in his foundation. Okay. Before starting our initial experience of mini-OPCAB in hybrid coronary vascularization, we focus the guideline in 2014, and we see that patients with complex multivessel coronary disease is recommendable an RTIM approach. We have to put the patients in the center of the model, where clinical cardiologists, interventional cardiologists, and cardiac surgeon all together has to decide what is the best strategy of revascularization. This is a provocative slide because sometimes it's very important that this centered care, patient-centered care, doesn't become a main paper-centered care. So I think that for hybrid coronary vascularization is a crucial point to have a very good RTIM. RTIM, I intend harmonious evaluation of advanced cardiac therapeutics. Together, everyone achieves more. So in the guideline of 2012, we see that the hybrid coronary vascularization is defined as the planned combination of Lima to LED grafting and PCI of one or more on LED coronary arteries. And at the level of the evidence of class 2B, this hybrid coronary revascularization is an alternative, an option to multivessel PCI or CABG in an attempt to improve the overall risk-benefit ratio of the procedure. Is no new concept because also in 1996, Professor Angelini, University of Bristol, he started with hybrid coronary vascularization with the mid-cab and the PTCA in a series of high-risk patients. And the results of this paper are very, very good. But this strategy of revascularization didn't have a good development in the future. I think that for the logistic reason, there are not very good cooperation between cardiologists and cardiac surgeons about also the sequence and timing of both procedures. Now, with the advent of hybrid operating theater, with new treatment like TAVI, with the creation of an RTIM, it's possible to have a good hybrid coronary vascularization. We know from the literature, there are a lot of randomized studies comparing PCI and the CABG. And the survival rate at 10 years was similar, also with the diabetic population. But in the PCI group, the rate of repeated vascularization was higher, while in the CABG group, there is a lower rate of relief from angina, but there is a major incidence of neurological events. We know that the population is aging, and in the projection is in 2050, we have about 20% of patients, of people over 8 years, so with a lot of comorbidities. So we have to we see sometimes we have the same age but not the same patients. We have to we must have a multidisciplinary approach for these patients. And I think we have to think about a tailored approach for revascularization. And we know that PCI is preferred in patients with lower symptom score, older age, good ejection fraction, And the CABG surgery is preferred with the higher symptom score, diabetes mellitus, and patients stable. And we have to consider in this diagram also the patient's wishes. So we know that the lima grafting has very good results in terms of index of patency rate. And this is a very interesting article. It's an anatomic pathologic study. Patients were treated previously with the CABG and were died for other reasons. And we know the difference. We know the difference from mammary artery and saphenous vein. Big difference is in 6 and 12 years. So because the mammary artery produce the endothelial cells produce cytokine that protect itself from atherosclerosis. And this paper, saphenous vein graft with the Prevent4, we see that the incidence of the patency rate of the saphenous graft is after 10 years, as of 50% are closed. Also, the incidence of neurological events. We see that in a group of hybrid coronary vascularization, we have low incidence of neurological events. The group of CABG group have increased the neurological events. And we can explain about the aortic manipulation. There are not a lot of other studies about that compare hybrid coronary vascularization versus traditional coronary artery bypass grafting. This one study of Ralph Farshamp showed the difference in 3 years. The difference in 3 years event rate is 8.8% versus 10.2% in favor of hybrid coronary vascularization. This article published in 2015 on Circulation review as a topic review. We see the difference from 3 groups, CABG, PCI, and hybrid coronary vascularization, with low, medium, and high symptom score, and low, medium, and high euro score. And we will see in group with high euro score, there are a big difference from patients treated with CABG on PCI or in hybrid coronary vascularization. For this reason, in 1997, Professor Benetti started with a new surgical technique. It's a mini OpCab. He was one of the pioneers of beating heart in the world. He was the inventor of a mid-cab. We started with this new kind of technique. It's very attractive, with a very small incision. The subxiphoid approach is only until 4 intercostal space. We harvested the mammary artery. We don't open the pleura. And we harvest only a small part of mammary artery until 4 or 3rd intercostal space. So this is the cosmetic result of the operation. And as possible is a small video. I don't know if it's possible to. It's possible to start the video.
Only if you have a file.
No.
If you can't find the file, then it won't play the video.
Yeah.
Can't find the video's not on.
No, it's on the.
It's not on this computer.
Yeah, it's on the computer. Have you seen? Okay, however, no problem. Okay, with this kind of operation, we treated 55 patients. The average age is 66, and one vessel disease is the most part of the population, and the 2 vessel disease on 22%, and 3 vessel disease only 31%. Every patient received a Lima 2LD, and other patients received the saphenous vein attached proximally to RIMA, to right mammary artery, and with distal anastomosis. The results of this operation are very good because in 160 months, in terms of also survival, also the major cardiac events. Only 10 patients received a repeat revascularization with the non-LAD lesions. For this reason, we think that it was possible to associate this surgery with the PTCA. This study will start with the primary endpoint. We have to start with the feasibility and effectiveness of the procedure and the major events, and with secondary endpoints, the percentage of patency rate, the evaluation of quality of life, and the cost effectiveness. This is a flow chart. Patients, screening of the patient with inclusion and exclusion criteria. Our team decided about the feasibility of hybrid procedure. We calculate error score as Sinta score, and we start with mini-OPCAB, and after mini-OPCAB, in one stage, the patients receive 300 milligrams of clopidogrel, and we start with the PTCA with the drug-eluting stent. And after 1 year, there is an angiographic control. During the PTCA, we check the mammary grafting. The inclusion criteria, we use every patient. Exclusion criteria, patients with congestive heart failure, redo, patients with previous stroke, or patients with the STEMI, or some contraindication to taking a dual antiplatelet therapy. This is our population. We treated with this kind of revascularization 10 patients. These are only preliminary results. The median age is 71, 2 patients and females. And the ERO score, the mean ERO score is a 7.6 with range 0.3, 19.3, with also patients with high risk. The Sinta score is a 35.2, the main Sinta score. 3 patients with the left main disease, 4 patients, 2 vessel disease, and 3 patients with 3 vessel disease. The bleeding is very, very low. It's 120 milliliters. And we didn't have any mortality after 30 days, any major adverse cardiac events. Only 1 patient received blood transfusion, non-conversion to sternotomy, and also the intubation time is very low, it's 1 hour, 0.5. And the total length of stay is 3 days. This is one of the patients, or the last patients, last month ago. This is the mammary artery on the LAD, checked before receiving the PTCA. And we treated the other lesion on the CX with drug-eluting stent. There are a lot of controversies also in the United States about the one-stage or double-stage hybrid coronary vascularization. And we see that in the United States, there are 361 hospitals treated with they adopted this kind of revascularization, and the most part of the hospital adopt the double-stage hybrid coronary vascularization. Only 83 centers adopted the technique with a single stage, one stop. We think that one stop is much better because is cost effective by reducing hospital length of stay, the risk of lesion destabilization, and also another thing, is important thing is the patient, improved the patient satisfaction. The only disadvantage, I think, could be the bleeding after the operation, because we have to give 300 of the loading dose of clopidogrel. But I think that with this kind of operation, with the mini-OPCAB, we reduce completely the possibility of surgical invasiveness, and 10 patients we didn't have any bleeding. As also compared to mid-cab, we don't open the pleura and avoiding the single lung ventilation. So the patients with mini op-cab as less painful than mid-cab because we don't open the intercostal space. At the same time, is easy conversion to sternotomy. We can have any problem, we can do sternotomy without problem, without additional risk for the patients. As direct visualization of anastomosis and also shorter operation can reduce the anesthesia and very low cost of the procedure. This is very important. Some US center treat with this hybrid coronary vascularization with robotic coronary surgery. TACAB is a very attractive option in hybrid coronary vascularization, but its widespread adoption has been slow and limited so only for a few centers. I think that because high complexity, long learning curve, high cost is important to mention. The conversion to open sternotomy in TACAB is 10%, so it's not so low. And also the length of operation require longer anesthesia, single lung ventilation. So for the patient is a little bit worse. These are some limitations of the study because this is only preliminary results. And in the end of March, we have a 1 year of follow-up. And we study with angiography every patient. And now we are creating all new dedicated instruments for this operation with a very small retractor, with a fiber optic, so we can start with a very small incision with good visualization of the mammary artery at the LAD territory. But we need some randomized multicenter trial comparing one-stop hybrid vascularization with mini op-cab with traditional CABG, op-cab, mid-cab, or also TACAB robotic. Okay, this think outside of the box is difficult for some people. Keep trying. It's a nice vignette, above all I think for surgeons. Sometimes it's difficult to think that it's possible to have another option to revascularize. Thank you for your attention.